Hello, everybody. I think we should begin because if we delay it, then that causes us to crunch time for the panel discussion and the Q&A session, which always get compromised in many of our discussions. So a very warm good afternoon. It's getting really heated up outside, but a very welcome to all of you to this session of webinar. And it is on the intersection of social norms, agency, and respectful maternity care. Today, the panelists, the line of experts will talk more details about it. However, I would like to talk that social norms and agency learning collaborative since last 2 years have been able to bring in multiple experts to discuss the concept of social norms and its intersection with different dimensions of human life in rural, urban context, in many other contexts. If we try to look into our construct from a socio-ecological model, we see that we have lot of learning available around where we see that how human beings in their societal level interact with social norms. But this is also an opportunity where the social norms and agency learning collaborative is trying to look into social norms across all levels and all dimensions of the ecosystem. With this at the core of the ethos of why this learning collaborative exists, I again welcome all of you. A quick, housekeeping things that keep the mics muted, and please feel free to put in your comments, questions, observations in the chat box. If you can specify if you have any question to any particular panelist, to any particular speaker, feel free to mention that. Then it becomes easier for us to facilitate that question to that speaker or panelist. If you have any questions for the Social Norms Learning Collaborative, we will be providing all the details of the contacts and towards the end of today's session. So please hold on to that, or else, as I mentioned, please put in all your queries, questions, observations, requests in the chat box. So again, with warm welcome, I would like to open today's discussion to the respectful maternity care. Although maternity care we have, just exact 12 months back, we did look into the intersection of social and gender norms within the 1,000 days concept of from the episode of unborn to a newborn child. We have explored from the societal perspectives. We'll try to look into the rituals, practices, and beliefs that influences the outcomes of those 1,000 days issues. Today is very important for us where we are lifting this entire respectful maternity care and the social norm intersection and looking it at the institution level. And how at the institution level it is being looked into, how social norms really impact the concept, how social norms can impact beyond that, and what is being done at the institution level to ensure that the maternity care is really respectful. With that, without taking much time, I would like to invite Dr. Aparajita Gogoi. And I'm sure you have seen that today's line of speakers are globally renowned speakers who do not need many lines of introduction. And because of the time constraint as well, I would be very short in their introduction, but no doubt Dr. Aparajita Gogoi serves as the executive director of an organization called Center for Catalyzing Change, a not-for-profit organization. Dr. Gogoi is a political scientist and an advocate and crusader for realizing the rights of women and girls. Dr. Gogoi was also named as one of the 100 most inspiring women in the world by The Guardian of UK in 2011. India Today, India's premier magazine, featured her as an unsung hero in the anniversary issue of December 2019. There's a lot to her credits, but let's more hear from her about today's topic and her experience about it. Over to you, Dr. Gogoi.
Thank you so much, Susmita, for that warm welcome, and a good afternoon, everybody. Vikas from Sambodhi, who's the speaker after me, and we will today talk about how we are looking at agency and norms in respectful maternity care under a project called Agency for All, which is funded by USAID. So I will try and cover my bit in about 8 to 9 minutes, and then I will hand it over to Vikas. Can I please have the next slide? So I'm going to start by sharing with you an overview of RMC and social norms and agency and how they intersect. Can I have the next slide, please? Since I'm the first speaker, I will try and define respectful maternity care to a certain extent. But what I'd like to really say is that, respectful maternity care is a universal human right that is due to every childbearing woman everywhere in the world, whether she's giving birth in a developed country or in a developing country. And when we talk of RMC, it means that women's autonomy, dignity, feelings, choices, privacy are upheld, that she does not undergo disrespect and abuse or coercion, and that her personal preferences, whether it is around having a birth companion, whether it is around having her choice of birthing positions, those are considered when she is undergoing childbirth. Often when we talk of respectful maternity care, we are told, oh, in countries like India or in resource poor countries, we are still struggling with infrastructure. There is a lot of stress on providers. There is overcrowding. And so we cannot provide respectful maternity care. And we would like to differ in a way because yes, there are all of us in our public health system. Service delivery is very, very challenging, but respectful care is not something that cannot be provided even in these circumstances because we convey the respect for women through our word, our action, non-verbal communication, verbal communications. You know, it is disrespectful to treat a woman differently because she belongs to a different class or caste, and that doesn't really matter about the factors around infrastructure or stress or overcrowding. So basically, what we want to kind of say is that RMC is an attitude, it's a thought process, and it is something that has to go alongside with other quality of care improvements that we are talking about. Can I please have the next slide? Just to bring you quickly up to date about the work that we have been doing around promoting RMC in India. It was about 2016-15 when we started talking of respectful maternity care. And there was a pushback from all quarters saying that, are we sure that there is disrespect and abuse happening? Do we know the typology? Do we know the kind of institutions where DNA is taking place? Are all women subjected to disrespect and abuse? So, in order to answer some of these questions and really do evidence based advocacy, we did multiple research in partnership with very credible institutions like ICMR, where first we try to understand the prevalence and then we try to understand the typology of disrespect and abuse, primarily in public facilities, and also try to understand what are some of the socio-economic determinants that drives DNC, or the lack of respectful care. Some of these are published research now. In case you want details, please feel free to write to us. We'll make it available to you. But moving on, armed with the findings, the research, the evidence that we had with other partners, we kind of got on to the advocacy bit. And today we are really happy to see that most of India's national policies like Laksh, which is a labor room improvement policy, and Suman, which is a safe motherhood assurance scheme, they all have RMC front and center and as part of goals, as part of objectives. And since then, we have been supporting various state governments in actually building the capacity of in-service providers in provision of RMC. I'm very happy to see Dr. Gadappa here today. He's one of the speakers. People often tell you that high caseload facilities cannot deliver RMC. And Dr. Gadappa is a walking, talking example of how he manages over 18,000 childbirths in a year, and there is still an enormous amount of RMC that is happening in his hospital. Similarly, we've also partnered with professional associations trying to get respectful care into pre-service curriculum, in-service curriculum. Recently, we have developed an e-learning module on RMC for healthcare providers, which also has certification attached to it. The other thing that we often encountered was the fact that women's acceptance of disrespect and abuse was really, really high, actually is really, really high. Women felt that it's a price that you pay for good quality care. It's the price that you pay for taking, services from a hospital. So in the last 5 years, we have done multiple kind of audience-facing campaigns in the demand generation space through print media, social media, television media, etc. But we still have a long way to go in order to kind of, help women or enable women to understand and ask for RMC. Can I have the next slide, please? With this, I have already spoken about this, that today I think India is in a in a much better place than countries nearby or far away, because like I had mentioned, in Lakshya and in Suman, RMC is integrated. And as some of you know, in 2018, India launched a cadre of midwives called nurse practitioners in midwife. And even in their guidelines and the learning resource package, RMC has been incorporated. Can I please have the next slide?
And you
Now
had
I'm
at
going to.
4 minutes. Sorry, just to check.
I have
I checked. Yeah,
I have 4 minutes left, 2 minutes left.
3-ish minutes. Yeah.
All right, I'll wind up. So getting to the meat of today's webinar, I think everybody on the call would agree that you can't really bifurcate social norms and agencies and women's empowerment. But in terms of respectful maternity care, I think there are aspects like lack of agency of women in decision-making processes, deep-rooted social and cultural norms, and how, for example, men see their role in aspects of life like childbirth, which really needs to be considered when we are talking of agency and social norm. The next slide, please. If you talk of RMC and you talk of agency, I often kind of try and make this case that in a world where a woman is not able to take any decisions about her nutrition, about when to get married, how many children to have, where she is overall disempowered, we can't really expect her to suddenly have the agency to ask for respectful maternity care. So the point being that agency, women's agency, sits within the wider empowerment processes. It sits within the wider network of social norms. So every time we look at agency and RMC, what we realize is that vertically trying to just improve and talk about women's agency just to ask for respectful care is something that is not going to happen. The second thing, and I know that Vikas is going to talk a bit more about it, is that even when we situate agency in RMC or any other processes, we have to recognize that there is a stage process. Just getting information is not going to help develop agency, but there are stages like can, act, and resist, which form the stepping stones to agency, whether it is to ask for RMC or other aspects in life. The third thing that we are looking at is also that agency rests at different platforms, different individuals. So how do we, even if you're talking of just RMC, how are we looking at how individual agency can impact it, how the agency of a married couple, how the agencies of a community or a community platform, and how can organizational agency or providers agency, all of them intersect when we are talking of situating agency in respectful maternity care. So as you can see, there are kind of moving pieces, overlapping pieces, and dynamically moving pieces when we talk of situating agency in a larger empowerment process or situating agency in just respectful maternity care. Can I have the next slide, please? So now coming specifically to how and where are we focusing on agency in this particular RMC intervention as part of Agency for All. I think so far the conclusion that we have is that, under building on some of these building blocks, that to change behavior, we have to give enough information to people so that they have to be aware about their choices. They have to decide that they want to make that choice. And most importantly, they have the power to act. I think if you are just aware of your choices, but you do not want to make a choice for whatever reason, or you do not have the power to act on your choice, then the path is only half covered. I think there is also the fact that just giving information, just giving awareness, just doing social and behavior change communication, even if I have the information, I may not be able to have the agency to change my behavior or somebody else's behavior. So we need to really consider how power dynamics influence choice. And the third thing that we want to talk about today is also about how your agency would change depending on whom are you talking to, or in what kind of a circumstances are you situated. So they may have agency in one area, but they may lose the agency in some other area. I think, for example, I have a lot of agency, but sometimes when I'm sitting in front of a doctor, I somehow maybe lose out on some agency to ask questions that I really want to ask, right? So I think that's just an example of how agency also differs depending on the situation that we are confronted with. The last slide, please. This is just, I want to touch on this before I hand it over to Vikas. As part of the Agency for All RMC work in the country, how we want to unravel some of these issues that I've talked about is really look at how engagement with community, with individual women, with community-based platforms through an SBC campaign, how will that really influence agency to ask for respectful maternity care. This would include working in facilities. For example, we are working in Dr. Gadappa's of Medical College. So how would all of this be impacted if we work with providers, with champions in the system? And I think the last sentence I want to say is that in India, we have focused a lot on the demand side of RMC, but not enough on the provider side. So a very, very interesting part of the project is also to see how we can support providers in order to deal with the circumstances that they work in, and also help them deliver respectful maternity care. I think I've taken a couple of minutes extra, but over to Vikas. Thank you
Thank
for
you.
hearing me.
Thank you, Aprajita. I think very pertinent and very interesting way of setting the context for us to understand the RMC. I would now welcome Dr. Vikas, and Dr. Vikas is going to present insights from the formative research at this on the slide. So Dr. Vikas and his team has recently done this study as part of the Agency for All project, and we look forward to listening from him that how the descriptive part and the injunctive part of the social norms and the role of reference group layout at the providers level, at the institutions level, and how the social norms really get formed and execute, and what are his studies. I think there is a lot of questions that we are going to learn from him in the study. Quick introduction, Dr. Vikas Chaudhary is Vice President, Public Health and Nutrition at Sambodhi Research and Communications Private Limited. He is a medical doctor and a social epidemiologist by training, with experience in working on public health issues, especially issues pertaining to sexual and reproductive health and rights among young people. No doubt, a long introduction can be given, but I welcome Dr. Vikas Chaudhary. Over to you, sir.
Thank you, Sushmita, and thanks, Aprajita, for setting the stage for me. I think you've covered a lot of ground that I was also thinking about how will I set that ground for. But thanks a lot for that, and a big warm welcome to everybody every participant. A lot of means it's a privilege that SNALC has invited us to talk about this, and I think it's an important part of how we think about respectful maternity care. Can we go to the next slide, please? So just quickly building on to what got us to thinking about these intersection of social norms and agency RMC. So just a quick glimpse into what the evidence and what the literature around RMC has been in an Indian context. So as Aprajita rightly pointed out, I think there's been a lot of work that has happened previously in getting RMC to the stage where we are. So I think while we have made improvements undoubtedly as a country and also within our public health and private health facilities around aspects of RMC, but like the road is long and winding right now. So we went back to the literature and saw what were some of the important gaps. One of the things was, while there is a strong, what do you call, the mention of the word RMC now in the Lakshay as well as the Suman guidelines, but where we lacked in looking at is that how are these guidelines and how are these standards converting into practices. And often, if you look at the practices and from C3 and ICMR works and even our previous work in Uttar Pradesh, I think we did recognize there are different kind of typologies that still existed within RMC, which were disrespect and abuse, both in a covert and an overt way. So I think that hadn't disappeared, even though these standards and guidelines were coming into place. But within the research evidence, there was very little literature from India that how do these provider norms, what is happening at the facility, what are these facility norms, how do they intersect at a community level with the woman or individual agency or a community level agency in terms of affecting whether there is you are able to demand RMC, as in a case of a woman who will come to the facility, or in case of a provider, whether they can, despite having whatever constraints that they work with. And I think some of the constraints we'll see as we move along, that what emerged, they were able to provide or not provide, and what do they actually articulate respectful maternity care as? What does respect mean to them? What does a women's agency mean to them in terms of the perspective? So a lot of provider perspective as well as the women's perspective is where we started with. Can we move to the next slide, please? And we decided to embark on this journey for the formative research, which was more around. We were very clear from the beginning that the formative research has to fill in the intervention gaps. And as Center for Catalyzing Change is right now in the process of developing that intervention and rolling that out, our idea was to inform the intervention in the places where there is already an evidence gap, or where we can actually identify opportunities for that intervention to be designed. And our basic objectives were to assess. So we went into facilities and assessed provider attitudes. We looked at their networks through which these attitudes either get formed or they get strengthened. What were the norms that existed at the facility level that led to or did not lead to some of the respectful practices? From the women's side, we interviewed women. We also interviewed birth companions, because we identified that birth companion was emerging as a very interesting, lever of what I would call the intervention later on, considering that was clearly also mentioned about having a birth companion of choice in the Respectful Maternity Care Charter that exists exists within facilities. Our study was mostly based on a social norms exploration tool and was more qualitative in nature. And we went to 4 different facilities, which are also part of the intervention as we move along. And one of them is Dr. Gadappa's facility. So we also wanted to learn that what was kind of some of the things that were working within that, and how could we strengthen that part of it, and also use that learnings from these facilities into developing the interventions for a bigger RMC provision, and so that women improve their experience of person-centered care. These facilities were a mix of we had 2 medical colleges, we had 1 district hospital, and we also wanted to bring in a private perspective. So we had a private hospital situated in Ranchi that was part of our research, and as we move along, it's going to be part of the intervention also. Can we move to the next slide, please? So I'm just going to quickly dive into what happened at a level of the facility, right? So some of these findings Aprajita has spoken about, but also some of the findings did exist in the literature already. So our formative research built on it, but it also built on it from the lens of trying to look at opportunities or trying to look at places where we can intervene, be it respect to a descriptive norm that occurred in a facility, or an injunctive norm, or something like which is a reference group which could be intervened with, or which could be made as our champions of change that we want to see within these facilities based on respectful care. That means, we know these rigid hierarchies that exist in the facility levels we could identify that some of the rigid hierarchies and the relationships between providers starting from doctor nurse or within different cadres of doctors or between nurses and the support staff, that was quite clearly visible in our social network analysis in terms of where these rigidities lie, who's the primary decision maker, and where do people normally go for their own for understanding or talking about their practices. Having said that, I think one of the things that emerged is that often at a facility level, the primary accountability of most facilities lied at the level of clinical outcomes, right? So they were very clear in saying that for us, our bigger responsibilities that the mother and the child go home happy and sorry, not happy, but more healthy in a certain way. So more clinical orientation, but none of these clinical orientations included or excluded respectful care. They just when we put them a scenario of saying that what if in a clinical complication something happens, the first thing that we started to realize that the sticky practices come out and the respectful care practices actually get deprioritized. Having said that, the interesting finding was that leadership across all of these facilities at the higher level, in fact, articulated RMC as the most integral part of clinical care. So I think we're trying to build on this opportunity to get leadership engagement, considering these leaderships were also primary decision makers and a big influencer in our social network analysis for most of the providers. So working with leaders, trying to create RMC champions, trying to create leadership engagement, get facility SOPs developed and operationalized at a level of the facility, something that we are thinking of in the intervention across providers. Sorry.
Sorry, we are at 2 minutes.
Okay, so I'll
Yeah.
quickly move into my next slide. Can we go to the next slide, please? Yeah, at a provider levels, while they all spoke about positive interactions between mother and child to be very important, I think one of the things that they perceived were that sometimes this disrespect and abuse is acceptable, and often these circumstances were associated with what Aprajita was talking about: infrastructural issues, systemic constraints, or overburdening and stress levels in the doctors, and they often spoke about it in terms of that's the reason. Some of the few facilities also spoke about the fact that, and there were few instances of it, that they spoke about how it is important for the non-cooperative women or the women who cannot be women who do not understand certain ways that the doctors are prescribing in terms of the things they need the women to do. And that point in time, they did speak about disrespect and abuse being acceptable. Often these clinical disrespectful behaviors were actually deflected into the to the junior staff, and that was where that came out as a certain things in trying to get which was also clearly visible in the hierarchies, but it was also something that we can think about using in terms of how we build these provider norm messaging across in our trainings or in our tools that in our orientations that we are trying to do, or in our mentoring and supervisory things, so that these provider norms are weakened and not strengthened in a way that they currently exist. Can we go to the next slide? I think that this one was more about the community norms, and I think I'm not going to dwell quite deeply into it, because Aprajita did speak to a lot about how women felt that it was very normalized within their thinking about the care that they get. Their care is often actually only associated with getting to go to the facility, having access to that facility for delivery care, and the concept of respect and disrespect and abuse were something that was often actually missed or not spoken about. Interestingly, one of the findings in this was that when we spoke about some of these norms of care, norms of disrespect and abuse, the people that identified particular instances and tried to describe those instances were actually birth companions, because often we can imagine the women when they're during their delivery, during the intranatal this thing, are going through an emotional journey, and often they may often miss the kind of disrespect sometimes shown, but birth companions were able to identify some of this behaviors that they found as disrespectful. Can we go to the next slide? I think that would be my last slide.
Yes, and yeah, time is also up, but yes.
Last, yeah, I'm just going to quickly talk. This one is a little bit important to talk about because one of the things that that came out from our research was also around how women are not able to complain about grievances which are about disrespect and abuse, and that was very important for us because we need to build this system of grievance redressals and feedback system purely for the women to get some thinking on their agency, that if there's something going wrong, they can complain to somebody. There's a formal system. When we spoke about them, there was lack of awareness around these formal system, but there was also and there was fear of this negative sanctions around raising this grievances, often because they felt that they may get worse care. They didn't know about it. Even if they knew a little bit about it, they would not go and raise this because they would feel that, okay, what if I don't get care, or what if they throw me out of the facility? Considering a lot of this was associated with the women's agency in terms of demanding it, not being able to demand anything because of the attachment they have with respect to what care means. And respect doesn't feature into that care. It's just access to a facility and being able to deliver. So I think that's where some of these findings were coming out, and that's how these findings are building opportunities to get into the intervention. We are like I think Aprajita said, we are just still working on our intervention design, and soon we are going to be doing some baselines, and maybe that would be interesting to see again after baseline what quantitatively emerged, as well as when the intervention is rolling out, what are some of the learnings we have. I know I have another slide, but I'm going to skip that. It's a little bit on agency, and Aprajita has kind of covered that part of can, act, resist to the RMC, that is. Thank you.
Thank you, Dr. Vikas, for presenting the findings from your formative research. I think all our audience have got a very good context setting for the RMC from the women's perspective, the birth accompaniment perspective, and how we are looking at the institutions level. With these two presentations, today we are going to now turn into a panel discussion where we would be looking into some of the efforts of the respectful maternity care being done at the institution level, where we have in our panel some of the service providers themselves who will be speaking about the issue, how do they work it out in there, and what are some of the challenges. And for this panel discussion, I would first like to invite the facilitator, the moderator. We have the moderator, Dr. Priya Nanda. She's a globally known person. Priya is currently an independent global health consultant with expertise in research, evaluation, grant making on gender and sexual reproductive health issues, rights. Her expertise and interests span, cutting across gender, intersectionality, understanding approaches to shift right-based practices within complex systems with a focus on gender, structural inequalities. Priya has many decades of experience of working with many international organizations, including BMGF, ICW, and other renowned organizations. So Priya, I'll stop with your introductions here and hand it over you to also introduce the panelists and get on to the discussions.
Okay, great. Thanks, Sushmita. What a lovely panel. Thank you to the two presenters. And we're just going to extend this discussion by bringing in three very esteemed colleagues who've been walking the talk on RMC. And it's very exciting to have all three of them here. I'm really doing a one-line introduction. We have Dr. Aparna Sharma. She is a professor of obstetrics and gynecology at All India Medical Institute, New Delhi, and specializes in fetal medicine, and she works extensively with Sarthak Initiative for incorporating respectful maternity care practices in public and private hospitals. She'll be talking about that today. Then we have Dr. Radha Reddy. She's a community medicine specialist with, again, decades of experience in public health, currently the head of public health and maternity services at Fernandez Foundation, which is also leading the national and state level midwifery educators project. for advancing maternal health care and education. And last but not the least is Dr. Srinivas Kadapa. Prajita mentioned him. He's a professor and HOD in the Department of Obstetrics Gynecology, Government Medical College, Aurangabad. And he has really pioneered respectful maternity care work in government hospitals, working with the White Ribbon Alliance, and is also the master trainer for the National Health Mission's Lakshya project. So welcome, everybody. I don't see Radha, are you on screen? Okay. So I'm going to just ask you my first question. We have 2 rounds of questions that we decided. My first question is for you, each of you, to talk for about 7 minutes on, Aparajit and Vikas have already laid the context. Now you can get more deeper into the work, building from there, the work that you've been doing in your institutions on RMC. What have been the entry points that you selected? What were the kind of interventions you've experimented? And any brief reflections on changes that have come about, that you have observed that have come about. So over to you, Aparna. We'll we'll go in the order of Aparna, Radha, and then Dr. Kadapa.
Hi, everyone. Hi, Priya. I'm really happy to be here today. I'd like to share my screen. Can you make me the co-host, please?
Is it all right if I share it for you?
I would like to do it myself, please.
All right.
So, thank you. So essentially, like Priya mentioned, I'm a maternal fetal medicine specialist, and I essentially work with, my area of interest is high risk obstetrics. So essentially, I work in labor rooms, and I deal with pregnant women, deliveries, and how I actually came across this is, over these lot of past years, I have been troubled by the disrespect and abuse that happens in the labor room. Now, why respectful care matters, I think we don't really need to tell this gathering, but the numbers that has always troubled me. And most importantly, the newer generation of people that is coming in. I am also a teacher. I teach MBBS students. I teach MD students. And also, what they see, what happens in the labor rooms is really, really, distressing. We know that, 13% of the cesarean sections or even the episiotomy that we are giving in is without consent. Almost 50% do report some form of physical abuse. We do vaginal examinations without consent. And pain relief is really not offered in labor room. And we do understand that whatever happens to the woman during labor can either empower her or damage, inflict a long-lasting damage to her in her future life. And this really is coming from what I have experienced during the handling of my patients during labor. So this has been troubling me for a very long time. And during the last 2 years, I got together with some of the like-minded people. Then I decided we needed some form of content there was some content already available. We do know there have been RMC modules. So how I started is we had a team of people who are leaders in their own field. For content, I got in touch with Pronto International, who has the experience of working with RMC. Then WHO India decided to fund, this initiative. And we also needed professional organizations. So for this, we had the support of AOGD, which is the Association of Obstetricians and Gynecologists of Delhi, because we needed a team of people who would be ready to take this up on a large scale, to disseminate whatever we are talking about. And also we had the support of the Delhi state. This was Dr. Jyoti Sachdev who decided that, okay, this is something that we need to do it on a larger scale. So something that we thought of as an idea, we were able to disseminate on a much larger scale. So With that, we had an agreement between the AOGD, which is a professional organization, and WHO India that we would develop the learning tools, we would develop the master trainers, AOGD provided the dissemination platform, and in the future, we build an advocacy to incorporate this in the undergraduate curriculum. So the important aspect is that we do understand that there is RMC module available, the content is available, but to begin with, we decided to actually tailor this module so that it can be disseminated to the people, to the service providers in a format that is palatable, in the sense that it can be received by the service provider in a definite amount of time. And it can be tailored to their requirements. So after that, we did the training of trainers, and then it was disseminated on a larger scale. So it started on December 2022. We organized that into 3 different parts. This workshop, it was a 3-hour workshop that we designed: birth needs activity, communication, and simulation. We do believe that the entire aspect of disrespect and abuse starts from miscommunication. So I think communication, we believe that is a very important aspect. And one very interesting thing that we started it is the emphasis on simulation, and that we have taken essentially from the Pronto International, and they have a simulation scenario for respectful care, and obstetrics is simulation intense. We have learned PPH, we have learned eclampsia from simulation, and we believe that simulation for RMC is the way forward. And we have had huge response from simulation for RMC. So we began with this initial training of trainers workshop, which was attended by public and private hospitals both. This was followed by the Delhi government coming in. So 14 district hospitals of Delhi came in the first phase. And followed by that, we had a plan laid out where all the delivery points of Delhi were decided to be covered over the next 1 year. And this we covered till recently, like 16th of March. And followed by this, we had one more workshop in April. So I think over the last 1 year or so, we covered all the delivery points of Delhi district hospitals, thanks to the support of the Delhi government. So interestingly, what started as an alliance between WHO India as a partner agency was taken up by the state government and implemented across the state. Some of the interesting observations which we came from the practices of respect. So I think definition of respect is something which is extremely variable. But some of the basic questions that we would ask is, do you introduce self? Are the relatives involved in decision making? Do you advise fluid intake in labor? Are you getting angry at women when they do not follow instructions? Have you observed other providers verbally abuse, or have you yourselves abused women? So I think these are practices which we have seen that they are taken as norms. I think they think that it's all right to do all of this. So I think some of the questions and the actual awareness about the universal rights of childbearing women. So I think one of the basic understanding is that if I am respectful, I am doing, it's not that the rights of the childbearing, awareness about the rights is possibly also not very great. So that was another thing that we really observed. And so these were some of the questions. So what is next for us? So regarding the sustenance, I think all of us who are hearing what I'm talking about would be, the question is, what was the effect of the work that we are doing? So essentially, I would like to answer is, yes, we have been linking up these workshops with a quality improvement initiative, which looks at the sustenance of this. So a PDSA cycle where the effect of the workshop is followed up with the improvement channels. But as we all know, the respect is an issue of cultural issue also. So there are measurements in place. So we have been able to start a QI project in 3 places, and we are following up with a process and an outcome measures with PDSA cycles to hardwire changes. But out of the 15 places that we have done the workshops, we have been able to start the QI QI cycles in 3 of these places. So I'm sure in the next 1 year, we'll have more answers. And interestingly, I have started thesis with my own, in my own place. So I think we'll have a lot more information in the coming months. But yes, our ultimate aim would be to have an advocacy policy to incorporate these principles in the MBBS and nursing curriculum. And I think till that time, this is what where we would like to think. So essentially, the next step should be capacity building for quality improvement. And I think that is where we have to think of when we talk about any change that we want to introduce. So unless people are able to identify the problem, solve the problem, why disrespect, how to approach this aspect, will not be able to bring about an improvement. So a lot of places when we did these workshops, we did couple it with a quality improvement workshop also. So that's what where we are thinking about. And I think that is where I would stop for now. Thank you very much.
Thanks, Aparna. This is great, fantastic presentation. And I think you've kind of touched on a few questions, especially the fact that you're doing QI and PDSA is of interest to one of the questions where they're looking at what is the kind of feedback mechanisms to improve RMC, because it's not a one-shot thing. It's a long process. So we can get back to that in the discussion. Over to you, Dr. Radha. You have 7 minutes, and then we'll go to Dr. Kadapa.
Thank you, Priya, and thanks to everyone for inviting us for this discussion. In fact, RMC is something I think that's close to all of us. So our entry point with regard to RMC was in the form of midwifery training. In fact, Telangana government, when we wanted to, Telangana government did a lot of work to bring in respectful maternity care into the system. And to begin with, there was this standardization of labor rooms where, the government felt that let's, refurbish all labor rooms and bring them to this standard, standardization where women can birth in utmost privacy and dignity. It started with that and then went on to there was this scheme that the government came up called KCR kit, where the women were incentivized to birth in the facilities. So that put a lot of pressure on the system because, the institutional births went up. So the next question was, how do we offer quality care? And then how do we bring down C-sections? So these are the two things that brought in midwifery. And I remember very clearly when this discussion around midwifery happened, that time then the commissioner, Ms. Karuna Vakati, she, called UNICEF and, other partners and said that, how do we bring in this quality care and bring down this C-section and especially this compassionate empathy care to the mothers? So that time midwifery came as one of the solution. And then when they looked around like who will provide this training to our nurses to become midwives, and Fernandez came as a natural solution. So then Fernandez was called on board, Fernandez Foundation, to train Telangana nurses as midwives. So one of the questions that, the challenge she threw at the Fernandez Foundation was that I know you will train my nurses as, very skilled and very capable, but can you bring in this attitudinal change? That was one question that was this thing. And so, but I must say that, this challenge was accepted by Dr. Evita Fernandez. And I still remember those days when in 2017, this training program started with a cohort of 30 nurses who were going to be trained as midwives. And this training started in Karimnagar district in Telangana. And, this 1 week, there was, in fact, RMC is a cross-cutting theme in the midwifery curriculum. So Dr. Evita and all of us would go and, there were a lot of reflections that were done with the nurses on, their own birthing experience, the way the mothers are treated. I think that brought about a tremendous kind of transformation, I would say, because most of them felt that, their own birthing experience was not good. And, as Aparajita and even Aparna, all of them have said that I think the birthing experience gives a very lasting impression on the mother. It either empowers her or it scars her. So then this brought about a lot of change within a week, and then they went on to get trained as midwives. But I must share one thing, that I think respectful care should start right at the doorstep. So there is this in the hospitals, lot of in fact none of the patients are allowed to walk into the hospital with their chappal slippers, so then they have to leave their slippers and walk in. So when we started this training program, we also said we'll leave our slippers out. But then this kind of when the staff saw this happening, they said, no, I think everybody should wear. So we started with small practices of looking at these minor changes but having a huge impact, of where you let every woman walk in with slippers. The security should not have a stick in his hand, and then even if they have to stand in line or whatever. So then there was absolute chaos in the OPD system. So setting right, giving them stickers, making them sit according to their trimesters, and the mother who needs to be seen. So bringing this kind of order. And not only that, I think this entire midwifery is also about continuity of care. So here we speak about empowering mothers, giving those choices to the mothers. So this respectful maternity care will come if a mother is empowered, to make a decision, to make a choice of what kind of birth she wants, the informed choice. So this, I think, the midwifery brought about all of this. And where then the mothers during the childbirth classes and birthing plan, they were taught about this entire process of birthing, and trusting their bodies, making decisions, and just listening to their body of whatever to birth in their comfortable position that they choose to birth. So these are some of the things, I think, that went on to bring a lot of change, because this was happening in one of the maternity care hospital, where even there were a lot of other doctors, nurses, other staff who were seeing, like, what is this happening. Then out of curiosity, we also had ashas, ANMs who would come and attend those childbirth classes, go through the exercises. Some of the doctors would try on those birthing ball exercises to see how it feels. So these are the things, I think, and this training was for a period of 18 months. So being there for almost a year, and looking at these changes very closely, kind of, I think, brought in, I would say, the entire atmosphere changed in the hospital. And I would say that I think this is I mean, it was also a policy decision from the government that let us introduce this quality of care. So it is whole lot of multi-pronged strategy, I think, that worked in bringing in this respectful maternity care. With this, I stop. Thank you.
Fantastic. I really wish we had more time for each initiative, but I really want to emphasize that, what you are doing is so different and so novel, and I'm sure Aprajita and others would agree. And I really want to emphasize the fact that you talked about these micro practices. It's not about just changing policies at the high level. It's like the everyday rituals and practices, and reducing the chaos and order, and giving women the choice, a dignified choice in how they want to birth, and also information about birthing practices. I think, again, this is just stating the obvious, but this is really walking the talk on RMC. Thank you, Radha. And now over to Dr. Gadappa.
Yes. Good afternoon. Thank you, Radha and Aparna, for sharing your valuable experiences. And I thank Aparajita for making our institute global and work on respectful maternity care. So I am going to share you my personal experiences of respectful maternity care, because we started in 2016, even before the Laksh program started. At that time, the respectful maternity care was just 4 line in a Government of India guidelines. So it was very difficult for us to implement. So we focused on certain important things like privacy, confidentiality, consented care, doula, and birthing positions. But when we started this, it was a lot of resistance, because now in 2014, when we talk about respectful maternity care, there are different guidelines, as Aparna has mentioned. Even they have come out with the toolkit. At that time, it was not like that. So it was a resistance. The biggest resistance was for the doula, because the doulas were not allowed in labor room, because we are having around 19,000 deliveries in a year, which amounts to 60 to 70 deliveries per day. And we are having a big waiting room, and there the delivery used to happen. So it was a all confidential way the delivery used to occur, and there was no practice of allowing a doula inside. So when we started training them and starting doula, initially it was a lot of resistance, because it was hampering their privacy, their confidentiality, and security of the newborn. This is what the healthcare provider were there. And in our department, it is the postgraduate department. So we are having 21 postgraduate students per year. So they are delivering this. So midwifery concept and delivering by staff is not there. So the new resident used to be trained each and every time. So the resistance was there for doula because of privacy, because you know that in labor room, many things were normalized. Because even in pre-service era, when I was there and I was trained in this medical college as a resident only, the enema, shaving, episiotomy, and no IV fluid, keeping the woman NBM, and for the fear of cesarean section, early cord clamping, these were the practices which were normalized. So we have to change all these practices, and we have to make the newer one. So initially there was a resistance, but we have trained each and every resident, staff sisters. We have taken the confidence of the superior authority like dean and administrative officer, and gradually the things have changed. And today we are practicing a wonderful respectful maternity care. But still I say, with the high case load, we are doing 80% of our job. 20% still we are lacking, due to changing population, younger generation, communication gap, and lot of deficiency in logistics. But what we have achieved in this 4 or 5 years is that, first thing is that the privacy, all the labor room is being made privacy, so that at least minimum curtains are there, so the woman privacy is taken. Secondly, abuse and high volume in the labor room has been reduced to zero. We are having the smooth music going in labor room, in antenatal ward, and in antenatal OPD also. So when woman is coming and she is sitting quietly, and then she is been examined, then triaging, I think, is a very important part of the component of the RMC, which we have started. So what does this triaging means? That it is not just applying a band to the woman. The doctors are not sitting in the cabin. They are going to the patient, those who are in waiting room, and they are identifying the woman who seeks, who requires urgent care. For example, pain in abdomen, bleeding PB, or she's having some symptoms like vomiting, headache, or she's a referred case. So these women are taken immediately, and then they are taken care of. So this has changed us and given us a quality improvement, that the high risk women are screened earlier, and they are given treatment, and we are getting a positive birthing experience. After triaging, whatever the examination and findings are there, whatever their disease is there, it is diagnosed, and then the woman is given a information along with their relatives, that what is her condition, when she is going to deliver, how much time she is going to require, and whether she requires a cesarean section. So everything is told, and so for that we have designed a vernacular language consent forms, that is in Marathi, so that even abortion, preterm delivery, antepartum hemorrhage, any preeclampsia, IUGR, placenta previa, all these consents are delivered in Marathi, and they are written. So they are reading it, and they are explaining to the woman. So once she has been seen, they are been explained, and then she is taken into the labor room. Now all the women are not taken in the labor room. The pregnant women who are not in labor, who are having early labor signs, they are taken in an antenatal ward, because it is a spacious ward and having little more comfortable situation. So unless the woman goes in active labor, that is, we call active labor as a 4 centimeter, though the WHO says it's 5 centimeter, but now we are following 4 centimeter guidelines. So till the 4 centimeter, she is in the ward, antenatal ward, where doctors are appointed. They are continuously screening them. They are taking their blood pressure, contraction, and FHS. And once they goes in active labor, then they are brought to the labor room along with the birth companion. Now, during this process of antenatal care, and when they are coming in emergency in intranatal care, the birth companion is trained. There are fixed 5 to 6 norms which are told to them by each and every resident, that what they should do, what should not do. So do's and don'ts are told to them. So the birth companions are very happy. And when a woman is accompanying a pregnant woman, then her 50% of anxiety is gone. So this has given us a very tremendous impact. Even we have studied in quality improvement cycles that the augmentation which was requiring before with oxytocin has reduced to less than 40%, because the anxiety level has decreased and the oxytocin is secreting and she is going in spontaneous labor. Secondly, the birthing position which a companion is allowing, the companion is giving her support, she's giving her, allowing her to move around in the labor room, and that ambulation has given a lot of immediate and early progress of labor. So no intervention is required. Secondly, the decrease in episiotomy rates, because episiotomy was routine when I was learning, even when in my pre-service era and in early service era also, that if a primary is delivering, episiotomy is must. But now with the alternating birthing position, with the doula in the labor room, with the proper training, the episiotomy is now judiciously and restrictively used. So we have dropped down our episiotomy rate to 8 to 12%, which was more at that time. So that has given her a positive birthing experience. Secondly, the alternating birthing position which she's taking, we have prepared photographs, we have sketched the Indianized photograph, different birthing position. We have kept this in antenatal ward, intranatal ward, and in the delivery room also. So they are going and seeing it, we are training them, and they are delivering very normally and naturally. So we are empowering women for delivery. I think that is the greatest satisfaction what we are getting here, because in past we used to deliver them. If she is not delivering, we used to threat her. We used to tell her that if you don't bear down, the baby may suffer. But now just the birthing position and the treatment and the training given to them, they are opting their own position, they are ambulating, they are taking nutrition. So there is no question of putting unnecessarily IV line for low risk patient. Now there is always a big question arises that whatever you are doing, these are all the old fashion treatment, what you are doing new. What will happen if the patient develops convulsion or bleeding? So I again say that respectful maternity care is to be given to the low risk woman first. And 80% of the women are low risk. Only 15% are high risk women. So for 15%, we are taking care and we are giving them the best treatment. So it is more than RMC. But for 80% of the women, it does not require any intervention, does not require medicalization. They can all be treated wonderfully and we can give them a positive birthing experience. So that is the another thing. Then cesarean section. So unnecessary cesarean sections, they are avoided by doing different Robson's classification auditing, interdepartmental auditing, and every time the senior person is on the floor. So cesarean section is decreased. And even if a woman requires cesarean section, at any cost, it is not delayed. So this is what even WHO says.
So Dr. Gadappa, just wind up, like maybe last 30
So
seconds.
lastly, I want to say only one thing, that the respectful maternity care practices, what we are doing, it's really working well. Only thing, it requires continuous perseverance, measurement, and follow-up. Thank you.
Great. Well, very, very phenomenal work again. We are very close to, we only have 10 more minutes for the panel. So I'm going to ask each of you to just come back on screen and talk about challenges. But to Radha, and especially to Dr. Gadappa, I really want to know, did you have to increase human resources to be able to do all this, or did you do it with the human resources that were already allocated? So I just want to, because that's always a question that comes up, that, there's human power shortages and we can't actually deliver. So, but I'll come to you in the end. So Aparna, if you want to just quickly talk about the challenges, I think your journey has just begun in many ways. So if you want to reflect on what's been said and discuss challenges, and then we'll go back in the same order.
Yeah, I think, like you said, I think it's quite challenging, and even Radha and Dr. Gadappa would agree that uh, it's like, doing it in batches. Every time the team changes, we feel that, we are there, we have people who have understood the thing, even in our setup every month. So we have this labor room orientation program. So every month a new team comes in and we are back to square one. So perseverance, like what Dr. Gadappa also said, perseverance is something that has to be there when we talk about respectful maternity care. And somewhere I really feel that, there is some inherent hierarchy when it comes to healthcare. The healthcare providers feel entitled, if I can say that, that they are at some pedestal as compared to the women in labor. So there is that thing which is very difficult to break. So I find these things a little disconcerting. And also, somewhere it is an issue of gender too. Women in labor, the same person would talk a little more respectfully to the husband or the relative as compared to the woman who's in labor. So these things do come across, but I think uh, these are things that we have to handle as we go on. So I think these are some of the things that I've felt, and we are trying various ways to address these challenges. Interestingly, what we have done now in our own institute is we have roped in the training personnel of the security guards. So security guards have a training, a team. So now we have trained the training team of the training guard. So I think that is, we are planning, in certain ways. So I think we have to resort to different measures to have that sustenance. I think that is the biggest challenge, because respect starts from the time they enter the door of the care, healthcare facility. So we can't say we can only train doctors and nurses and the security guards can just do whatever they want. So I think that is some of the things that I would like to mention here.
Yeah, and thanks for bringing in gender, Aparna, because that was one of the points I wanted to make, is that gender norms are very different from social norms. So here we're talking about deeply ingrained gender norms. And the issue of consent that you are talking about, and even Radha talked about, actually women don't even have consent in many other aspect of their lives, So it's just seamlessly translates into not having power, consent, dignity, respect, even in healthcare settings. So I'm glad you brought that up. So I hope there's time for some more discussion in the end. Dr. Radha, over to you.
Yeah, thanks, Priya. I think coming back to this challenge, I think the biggest challenge that we have faced is somehow this childbirth is entire, I think it's a family business, I would say. And it's the entire family that is involved in decision making. Like, even though we prepare the mothers so much for natural birth, but the family members put tremendous pressure, like, oh no, we can't see our daughter going through these pains, they want C-section to be done. So this is one of the biggest challenge, because everybody wants to interfere in her birthing process, and in a way, like, they kind of take over. That is one challenge. And second one that you asked, that do we need more HR? Is HR a constraint in giving respectful maternity care? I think, coming to that question, in fact, during our training, as Aparna said, simulation is such a powerful process of training or even demonstrating something. So we have repeatedly demonstrated that, you know within the given time, uh, speaking respectfully, or giving that respectful care, and it takes the same time. Actually, it's not like, by being respectful care, you are in fact prolonging or whatever. You won't be able to see as many mothers you want to see. So we have done that several times. And we have also given them small steps, baby steps, on how to bring about this respectful maternity care, like just by introducing yourself or calling mother by name. These are the things. So one is identifying these challenges, and then finding solutions to them. even in terms of these family members, that's the reason where we say that even family members, we make them sit in this childbirth classes so that they listen to what, what kind of this thing is given to the mothers, what kind of education, how they are empowered, so that the family members also in a way become advocates for the mothers. So these are the things, like, identifying, addressing them, again making things work. So yeah, I hope I have answered. Thanks.
So Dr. Gadappa, over to you to in the way you discuss your work. It is so phenomenal, and it seemed as if it was so seamless. But obviously, there were challenges. So,
So the challenges which we face are that the residents,
you can like really,
they are coming
yeah,
every year.
please.
Even the staff are changing. So these are the biggest challenges. So we have to have a continuous ongoing induction program. So whenever the new residents come, the old resident, they only teach them how these components of respectful maternity care and other parts of that are there. So we take a repeated changing. So that is a big challenge. Changing staff sisters, because there is a norms under Laksh that the staff sister should not be changed in the labor room. But in a medical college like us, there is a continuous change every 6 months. So it is a biggest challenge to train those staff sisters about the components of RMC, because this RMC, these things, they came right now, but there are the old staff sisters, they think certain things are normalized. So it is very difficult to just not only train them but change their attitude. So that is the biggest challenge we face. And then, as Aparna said, security, because we are training the security which is in front of our this thing, but they are also changing every 3 months. So sometimes approaching these people and training is very big job. But fortunately, the White Ribbon Alliance C3, these people are helping us, and we are doing some sort training.
So, one question I have for you, and several, it's also in the chat. Is there an active grievance mechanism that's being used, because now RMC is an issue that has been brought out and you educated the client and the women and families about it? Is there an active mechanism for grievance redressal?
Yeah. So under RMC, even in under Laksh, we have got these complaint boxes. They are lodged, and there are our residents every 8 days. They have got that 25 questionnaire. So at random, we ask the questions. So these are the two ways. And those who are having complaints, they can put in complaint box, or they can complain to the superintendent. The nameplate is made like that, and that is put in every ward, that if you have got any redressal or any complaints, you can complain. So this is what facility we have started.
Yeah, in AIMS also
Yeah.
we have
Yeah, go ahead, Aparna.
ward-wise QR that you can to put in your complaint. So it's a very active mechanism where you have, and actively collected feedback is there.
So, one question I have for you all, I mean, it's a lot of the questions that are in the chat are actually getting answered, so I'm not going to read them out. But one question, Aparna, you talked about changing culture. So, Dr. Gadappa, when you broke down RMC, and actually all three of you, there was the softer elements of it, and then there were things that were very, very much about clinical quality. And you can actually link it to clinical outcomes. And you specifically talked about that C-sections, episiotomy, etc. Now, what I want to know is the softer elements. How are you shifting the culture and the soft elements? If somebody can talk about and I think rather you talked about micro practices. Are there any other examples that are really helping shift that, the empathy, the dignity, the things that are not easy to observe and quantify?
I think one is role models, Priya, because what we have seen is like the ones who got trained in 2017, those midwives, they started, when they actually went out to practice, it was in 2019, they actually started practicing. And when government of Telangana called for next batch of NPMs, there was a tremendous response actually, who the nurses who applied, because they saw these midwives doing something very different, being very patient, very compassionate. so nice to despite their own hardships, their own challenges, they saw that not once they were, rude or, disregarding mothers. So in fact, in the interview, like Fernandez was always on the panel of their interview well selection. So the one thing that when we ask them what made you apply for this, they would say that, oh, we want to be like that, she is so amazing, so I think this role modeling is.
So, let me get to the core of the issue, which I want to probe on: power, right? A lot of the labor room nurses actually don't have, or midwives don't have power in a very, very hierarchical gendered systems like Aparna is talking about. So how do you actually create a culture where you create more power? Because I know Dr. Gadappa's worked on this, but he didn't bring it up in this presentation, where there's disrespect and abuse that healthcare providers themselves are facing within healthcare facilities. And how do you shift that in order to really make sure that RMC gets translated? Dr. Gadappa, do you want to come answer my question, and then
So
we
this is really very important part, because the disrespect what the staff sisters are facing, because it happens sometimes.
Sorry, Dr. Tyagi, can you go on mute, please? Yeah.
So this happens most of the time, and most of the time even they are facing some problem at home and they are coming to the work and now they are disturbed. So sometimes their mood is also not good. So this is the time that when as a consultant we go there, we not only talk to the resident, we talk to the staff also. That is everything is okay. And definitely she will come out and say that something is going wrong. So she should be given a special care, and we ask some other staff to accompany us. That is one thing we do. Secondly, we make champions among them. So those staff, because they are 24/7 in the labor room. So those staffs who are working very well, we are making the champion among them, and we are felicitating them whenever the chance comes. So that is another thing. Secondly, that if they want some leave or they are having some sickness problem, we help them to solve it, and we give them break whenever they require. And the feedback is very good.
Priya, can I also?
Yeah, please. And Vikas, you can come back.
Just to add to what Dr. Gandappa was responding to, I think what has helped in our experience so far is to also promote respectful maternity care as a collaborative model. Because often when you just speak to them, some doctors may say, "Arey, hum to nahi kar rahe, it's only the nurses who are doing it." Nurses will say it's only the support staff who's doing it. So as he was mentioning, in the training and introducing RMC in a facility, just kind of promote the fact that it's a collaborative model and not one person is responsible or one cadre is responsible either for RMC or for disrespect. So I think going in with that lens really helps. And as you heard Radha and Dr. Gandappa talk about, disrespect starts with the security guard, chasing people with a stick, or, telling that, okay, we can go in wearing our shoes, but you can't come in barefoot. So I think it is this no blame, no shame, let's do it together. I think that would help resolve the power dynamics to some extent, but hierarchies will always remain. Over.
I just want to add on to what Aparajita said. See, I think this collaborative model, I totally agree. That is one way of bringing both the midwives and doctors to work as colleagues and collaboratively for the mother. In fact, one thing that really worked for us Yes, sorry. I just want to add one thing where the midwives, in fact, collect the data and they kind of present to the doctors on the data, the work that they have done. And seeing this amazing work, I think sort of, brought in that whole lot of respect and care for each other. That is another thing that really worked in the favor of, yeah. That's all, Priya. Thanks.
Then Vikas, if you wanted to add anything. Yeah.
No, I mean, I completely wanted to talk about Prajita's point of the collaborative nature of it needs to be a team effort. And often what happens is when you're in the facility, what the research or what the earlier evidence exists is also that it's not that service providers don't want that. There is a positive interaction thing that they always cherish. So when we spoke to some of them, they speak about how the, like, the women were happy, and some women spoke about specific doctors. So there is a certain amount of positive interaction that they believe in. And I think the norm, if we can somehow bring in this norm that clinical respectful care is not separate to clinical care, I think it is a part of the clinical care continuum or whatever that, and it's an integral part of it. I think that something may bring about culture change. You're right. Like, the meta norm shifting is not something that we are able to achieve, and in, like, intervention sometimes. I mean, that's going to take us a long time to come about. Thank you.
Aparna?
I just wanted to add a point about, how to bring about a change, the thing about the empathy, So one is, of course, the role modeling that Radha has been talking about, and also incentivization in terms of actually appreciating. That is something that is so underplayed in a government setup. Just saying you're doing so well. I think we've forgotten to say that, but it is so much appreciated, and I've seen the power of appreciation. So I think that is something that we've used, and it really works. And the third thing is, midwifery is not yet there in most of the primary places, and all of that. But what I've really seen is that people have forgotten how to talk in general, how to talk with empathy, with, just, to patients. So the simulation really works. Just to tell, and in the scenarios that we build, or, how to just say that, unless you tell me the finding, once you've done a PB examination, you have to tell that finding to the patient. Simple things like that, just reinforcing those things. And to come back to the thing that, once you enter the room, just cover the patient, talk to them, ask how it is. So I really feel that, simulation is a very powerful tool when it comes to even, teaching soft skills. Till now, we've used it, extensively for clinical skills, but I think it's time to use simulation in a big way for teaching soft skills. And we are really trying to do that in whatever way that is possible.
Great. I see Vinaya on screen, which means our time is up. I'd like to just maybe wind up with a few points I want to emphasize. Firstly, this is such a fantastic panel. Vikas, you can come back on screen so I can thank all of you, and Aparna, all the work. And, really, I have seen the beginning of this journey. Aparajita is there. I've seen how this is a building block, and new people and others have joined, and different entry points have been used, which is really interesting. It could be just somebody's own personal value system conflicting deeply with what is happening, versus using an entry point where you have a large new cadre of midwives to be trained, or really doing a very 360-degree approach to improve clinical quality, which you see is lagging. Whatever it is, what we are seeing is very common principles and values that are underlying RMC in all the practices that we've heard about today. And I think what would be really interesting is to say, each of you talked about their own curriculums or your own content, to really look at, and some own different measures. Aparna talked about some measures, Radha talked about some measures. I think creating a common standard around that, since the research is happening, Vikas and Aprajit, that would be really important, because to be able to say, women report that consent, just having consent or being respected by better communication actually eases trauma, or just having a better trained birth companion helps them. These are clearly measurable things. And of course, there's a lot more that you all talked about. I'm just picking a few things. I think that for me, this is one of the panels where, after a long time, I mean, a lot of us have been talking about how do you really mainstream gender and health systems. And it's a very top level discussion, and talking about the centrality of power. RMC really brings it right to the core. And this is a panel where you're really seeing the convergence of evidence and practice, and how the theory and practice are working in very symbiotic ways, and they're really informing each other. So fantastic, and congratulations to all of you for the work that you're doing. And back to the organizers.
Thank you so much. I think as someone who is new to the field of RMC, this was really, really, just basic behaviors that all of us understand and how they can result in such huge institutional change. And for the mothers as well was really exciting to hear. Now back as a organization of the Social Norms and Agency Learning Collaborative, I have few quick updates, literally 5. So I beg you to stay on for 5-10 more minutes and we will be done. Just let me share my screen so we can go through them. And I knew it would be quick updates, so that is what the presentation says. Wow. Our very first update is that we are starting monthly meetings, and for that we are starting with members from Bangladesh. Yes. So since we are we are the South Asia Learning Collaborative, so we are starting with members from Bangladesh, and it will be happening on 30th May. So if we have people from Bangladesh here, I would love to invite you as well. Reach out to us on our mail ID. And it will be for around an hour where we'll set expectations with each other, expectations we have of the members and members that have of us, and we'll also explore scope for future collaboration. So I hope to see you there. And after that, starting from June, we'll have monthly check-in meetings with all members. Obviously, voluntary given your time and resources that you have at the moment. Again, this will all be virtual and it will only be open to registered members of SNLC. These won't be open events. Here we'll kind of discuss openly social norms and agency related concepts as they appear in your readings or your work. We'll also take updates from members about their work and we'll explore future collaborations and we'll have a lot more exciting things on the agenda. Thirdly, we have an annual member survey that is a part of the collaborator so that we have a direction to work in the future. So please expect to have it in your inboxes in July 2024 and we hope to receive responses from you. Lastly, our next webinar will happen at the end of June around the theme of children, adolescent, social norms. And like institutions was one of the levels that we were operating for this one, we'll have another level or the same levels with the interaction of other levels for this webinar. And lastly, as usual, we have a call for resources. We are openly accepting blogs, video bites, technical pieces, and case studies from members and non-members. And it would be great if you could join us and contribute to this growing body of work. So please reach out to southasialc@gmail.com. And if you want to see past resources, you can take a screenshot of this slide and go to the QR code, scan it, and yeah. That was the end of the 5 updates. I would like to thank every single panelist and every single participant for this webinar for cooperating and staying tuned and engaged. Thank you so much.
Yeah, thank you, everyone. Thank you. See you in some more next webinars. Thank you.
Thanks, everyone. Bye-bye.
Thank you.
Thank you.
Thank you.
Thanks. Bye.
Bye. Thank you.